Seriously, I just thought this was never getting Hey, so guys, you're going to read your site, and you are in the lungs. So we are going to list as a class. Y'all list with me. Lungs, pulmonary veins, left atrium, LAM, which you all know what that stood for. Left AV mitral bicuspid. Left, say it loud, ventricle, aortic valve, aorta, system, inferior or superior vena cava, right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary arteries, lungs. No, that wasn't one. Are we good? You didn't have to put lungs again at the end, but okay, come on. All right, so you have to go back to the lungs, right? So, okay, how'd y'all do? You did okay. So good. So let's continue on today. Everybody good? Anybody have any question for me? Let me say this, and I need you all to hear this. So Wednesday morning, the lecture quiz will be anything that we've talked about in the heart. So anything back to the beginning of the heart. So chapter. So go back through anything that we've been discussing, okay, in your notes. Because I really wanted you all to also be ready for a regular lecture quiz today too. I told you this one was a gimme one. That should be a 100, but you should have been also ready for any of the other as well information. We will be having a test on this either next Monday or next Wednesday. The test will include hematology, cardiology, and the vessels, the vascular system, which is the next chapter. So I think a lot of you all hate Monday tests. Is that correct? Would you all rather to have that on Wednesday of next week? All right. So pace yourselves with the study. Do not study right before, right? So be pacing yourselves with this information. This next test will include those 3 chapters: hematology, the heart, and vessels. Anything that we talked about, anything in lecture is fair that we put in there. Certainly blood flow through the heart would be something that you know by that, if you didn't know it today, by then. But any lectured material, any deeper insights, and any disorders, right? So that will be a test next Wednesday. Fair enough? Everybody's got that on their schedule. You know about it. Today in lab, we will be looking at hearts. So we will be looking at hearts today, and on Wednesday in lab, we will be taking each other's blood pressures and pulses. Okay? Everybody stays. No breaking up for this one, okay? Are we ready to continue? Good. Okay, so we had talked about ECGs, aka EKGs, and we understand we're going to need to know what the P wave represents, what the QRS is representing, what the T wave is representing. We need to know that and understand about this cardiac cycle, that systole or systole, either one, is contraction. Diastole is actually relaxation, what those terms mean. And that for when we think about a heart rhythm, we realize it's really 2 pumps, but it's those 2 pumps working in synchrony, and the heart rhythm is going to include the atria relaxing and filling, then contracting, the ventricles relaxing and then contracting, and then a refractory or quiet period. That's one rhythm, correct? We talked about what tachycardia versus bradycardia means. We understand what an adult resting heart rate should be depending on the person, you know, what their resting heart rate should be. So we covered all of that. And I think that at the end, I was sort of pushing on you, and I get that I was pushing on you something called cardiac output, CO. Cardiac output. Cardiac output is evaluated, I told you, CO is evaluated by taking heart rate, and that's beats per minute, and multiplying it by stroke volume. And stroke volume is really referring to how much blood is being ejected from the heart. So Why couldn't cardiac output be based on just one stroke volume, like how much blood is being ejected? Because if the person's heart's not beating as often as it should, would that really give you an idea? It wouldn't, would it? So you have to do it over time, and the time that they do it over is a 1 minute period. So heart rate, which means beats per minute, BP, however you do that, BPM. Okay, beats per minute, I have to think about the letters. Heart rate times stroke volume gives you a cardiac output. And I told you that the thing that you want to be thinking about that for your patients is that once you figure that out, then a cardiologist would also figure out what's the person's maximum and what is their, what is their resting one. And if there's no difference between, the difference between is called their reserve, isn't it? But if there's no distant difference between, that it means that person, are they very much at risk for a heart attack or cardiac arrest? They really are. So, so this is how you figure out like how much a patient should be doing and whatnot. So that's kind of how I ended that. Does anybody have any questions about that? You get to some of these notes too in your book. I'm not making any of this up. It's all in your textbook, right? So you'll get to some of these in a little bit. I want you to be thinking, though, always from this point on about this ventricular output. Ventricular output meaning those ventricles, how much they're ejecting. And when they're ejecting into these vessels, and it must be synchronized between the right pump and the left pump, because please know this. If there's not balance between them, then fluid is going to build up in one place or the other, either the lungs or the system. So let's see if this doesn't make sense. If right ventricular output is exceeds the left, because the left pump's not doing what it should be doing, it's going to be backing up, and fluid's going to be backing up in the lungs. Does that make good sense to you? Because we said it's a closed vascular system, isn't it? So this ventricular output has to be balanced. We said when it's not, we call this congestive heart disease, sometimes congestive heart failure, right? When somebody is diagnosed with this, sometimes their first diagnosis comes when they're in your ER, because they are all of a sudden, they can't breathe. they're having trouble breathing, or they feel like something's sitting on their chest, or they feel like they're having a heart attack, or can't breathe. So they're in your ER, and you throw around, as medical professionals, you throw around this term after you've done some of your vital signs and your x-rays, and you see they've got some fluid around, you can hear the fluid around their lungs, and you say, well, you got CHD, and they'll ask, well, what in their family members, what's CHD? Congestive heart disease, or maybe you say failure. To a non-medical person, that is frightening, isn't it? Watch how you throw those things around, because I've seen families panic in ERs when medical professionals throw terms around that are very common to them, but it's not common to family members or patients. So all you did was exacerbate the situation. So, but what you want to do is know that some people can get that diagnosis in your ER, and with proper care, they can live for a decade or more, But what was the key part about that? Proper care going forward, right? So, so it is a serious diagnosis. It is a serious diagnosis, but it can be managed, hopefully, and will be managed. Hopefully will be managed. So when the right is outpacing the left, meaning the left's not doing what it's supposed to be doing, then fluid will back up in the lungs. That's called pulmonary edema. And you should know it's called pulmonary edema. When the left is exceeding the right, then again, maybe it makes sense to you, if the right's not doing what it's supposed to be doing, blood is going to back up in the system. So this is going to give you really systemic edema, meaning, ankles, feet, fingers, whatever. By the way, some edema in those areas can be kind of normal, depending on the situation. If somebody has a job where they're standing on concrete for 8 to 10 hours a day, can they have some systemic edema? Can they have some of that? They can, and that can just be, whatever. But yeah. So anyway, So this is what happens here. Does that make good sense to you guys? This is referring to the cardiac output, so y'all can review that. Infants have higher heart rates than adults do, so we said we understand they're different normal values depending on which age group you're looking at. Pediatric medicine is a completely different beast. Do know, though, some of the more common. So we typically think about adults being between that 70 and 82. But we can have athletes who have a much lower heart rate, beats per minute, than someone who's not as healthy. And that's because their stroke volume is so high. Their stroke volume is so high, do they need to beat as often every minute? No. So it can really go down pretty low. My dad had a resting heart rate. He was 6'4". He had a resting heart rate until he was in his 80s of 40 beats per minute. That could freak some of his health professionals out when they were doing his pulse and doing his vital signs. They would be thinking, But that's because he was, he'd been pretty active most of his life. Was very, his stroke volume was high. So did his heart need to beat as often per minute? No, it didn't. You got somebody who's got a little bitty heart, like a little bitty person, and is it going to have to beat more often? Is it? It is. So anyway, I want you to know two terms, and these two terms are, and I don't like the way your textbook gives them to you, so I'm going to give them to you the way that medical people use them. And it looks so kind of weird here. But anyway, chronotropic versus ionotropic effects. So I just want you to know these two terms, because when you look up meds, sometimes the meds will say it has a negative chronotropic or a negative ionotropic or positive, you know what I mean? So I want you to have heard these terms. Chronotropic is going to mean that it's going to affect the beats per minute. So if it's a positive chronotropic effect, what are you expecting this drug to do to the person's heart rate? Raise it, exactly. Or if it's a negative chronotropic effect, obviously the heart rate's going to go down. My dad, true story, I took him to the ER one time. There was some over gangrene in his toe. It had nothing to do with his heart rate. I knew his heart rate was low. But he went in there, and his heart rate was lower than the 40. It was like 32 beats a minute. And come to find out, when he was saying what drugs he had been put on by the last doc he'd seen, a doc had given him something that was a negative chronotropic drug. Do you give somebody who has 40 beats per minute a negative chronotropic drug? No, because he got put, not because of the gangrene, but because of his heart rate. A crash cart was brought with him and taken with him all the way up to the ICU until they could get that drug out of his system. You understand, this is important to know. You need to know baselines for your patients, and then you're very careful about drugs and how that will affect them. You don't give somebody who has a low resting heart rate a negative chronotropic drug, do you? That would make sense not to do that. So anyway, I want you to know ionotropic is different though. This is going to be something that actually increases the strength of the contraction. So that's a very different thing. So ionotropic is a positive one. It's going to increase the contraction strength. And by the way, they're not always drugs, or some of our hormones going to do this. When you guys are in fight or flight response, does your heart rate go up? So epinephrine, norepinephrine, these are positive chronotropic natural substances, aren't they? Epinephrine. How about the contraction strength? Does it also affect the contraction strength of your heart? Yes, it does. It causes the heart to pound. Not just in increasing beats, but also contraction strength. So we get that. Sympathetic nervous system. The parasympathetic is going to slow it down. So we have naturally occurring hormones that also do both of these, positive and negative effects. I just want you to remember that. We remember the sympathetic is our fight or flight, don't we? We remember the parasympathetic is going to be the vagus, stimulating vagus nerves. And remember the vasovagal response. That vagus nerve releases acetylcholine. Acetylcholine slows your heart rate down, has a negative ionotropic effect. Are we good? All right. So do emotions, do those kind of things play a role? Do they? Yes. Yeah, they really do. We have chemoreceptors as well. These are specialized receptors. Remember, in the nervous system, were all neurons created equal, or did we have special neurons that detected temperature, special neurons that detect pain, special neurons that detect pressure. Those are baroreceptors, right? And special neurons that detect chemical levels. So we have all of these that are contributing to what your heart rate is doing. It is not just exclusively based on the SA node. What does the SA node stand for? Sinoatrial node. And this is going to be the, where is it located? Yeah, no, upper right atrium. All right, so we've got a lot of different things that can play a role in this. Do you think exercise can help your heart? Yes. I'm sorry, today, you don't hear me? Okay, y'all don't care. But okay, anyway, absolutely. And so we know that exercise can help in so many different ways. Now, if somebody, is there a safe way to approach it? Exercise, yes. So knowing a safe way to approach this is going to be important, but absolutely we know it can do this. And so it increases cardiac reserve, which we said is what we like to see. Somebody who has a huge difference between their resting CO and their, CO at exertion. And then I want you to know about atherosclerosis. This is going to be a transverse section of an artery. Y'all know transverse means what? What does transverse mean? Across, right? So you take this artery, you make a slice across, a thin slice, and take a look at it. And when you're looking at it, the lumen is the opening, the inner, space. That's what a lumen is. But obviously in an artery, in a living one, it would be filled with blood. Isn't that right? And with each pump, blood is pushing through, right? So in a normal artery, you would see this nice large lumen, and you see the muscle. This is a middle muscle layer, endothelial layer. But in somebody who has atherosclerosis, hardening, which is sclerosis means hardening, doesn't it? Hardening of the arteries. Then what is going to happen here is that this inner endothelial lining, plaque formation will occur, and it will start separating those linings, and it will continue to separate and grow the plaque formation until now. Look at the lumen. Y'all see the lumen there? So this is when they say that somebody has like 90% occlusion. You can see, have you lost at least 90%? I would say at least 90% blockage, maybe even complete at that point blockage. The arteries themselves, arteries are really rubbery. They should be like, they're thick and rubbery. And if you've never felt them before, you'll see them on the specimens that we look at today. Of course, they've been preserved, so it changes the consistency a little bit. But anybody who's ever maybe killed things and eaten them, right? I don't know, whatever. But if you've ever seen arteries, they're really thick and rubbery, and they're strong. But somebody who has an artery like that, it is hard. It is hard as a rock. An artery is nice when it can actually expand and rebound. Because when an artery is getting blood, think about your arteries getting blood from your heart. They're having to expand a little bit, but then they rebound because there's elasticity too. When they do that, is that actually in itself helping blood to flow? When an artery can do that, is that helping blood to flow? It is absolutely helping blood to flow. Don't tell me arteries pump, because they don't. But because they have elasticity, is it helping? It is actually helping. But what happens when they start to be hard? And when I say hard, guys, one of the last ones that I saw, and it was impressive, on autopsy, at an autopsy conference we went to, and my students got to see this too. They had a descending aorta from a patient that was laying there, and you could take your finger, and it should have been a rubbery thing that bounced right back, right? And instead, when you took your finger and pushed, it cracked. I have no idea how the person lasted as long as they did. There's a scale they use that I think is a European scale, and it goes from a 1 to 7, with 7 being the hardest arteries, and this one had been evaluated as 7, the hardest. But anyway, hardening of the arteries is not a good thing. So, any questions about that?
What is
Yes.
the lining called? You said the lining of the artery.
Oh, it's endothelial lining. We're going to see that in just a second. But arteries and veins, both the middle layer is the important layer because it's muscle. And does smooth muscle have the ability to stretch? But then it also has the ability to rebound. And that's the important thing about muscle, is that it can do that. Smooth muscle can do that. And so both arteries and veins both have this muscle middle layer. Any questions for me? All right. All right, so this chapter has a lot of neat information that we've kind of talked about. But some of it is maybe new or not completely new to you guys, because I know y'all have some background in this. But we do need to talk about these vessels, because obviously it's not just about the blood, though it is about the blood moving to tissues to deliver nutrients, pick up waste products, deliver things to the tissues that are stationary. You know, its tissues are stationary. They're relying on this liquid tissue called blood, liquid connective tissue. And the pump, obviously, is what's pumping it. But do we need the integrity of the vessels being maintained as well? Yeah, so now let's take a look at those vessels and let's see if this doesn't kind of make sense, their anatomy. When we think about the anatomy of them, does anatomy help us understand what their function is to be doing? It does. So in a nutshell, you all told me that the heart pumps blood out to vessels called what? Arteries. Y'all already knew that going into today, that the ventricles pump blood away from the heart into vessels called arteries. Didn't you say that? And arteries, by the way, some arteries are large. The ones closest to the pump are large. Then they get smaller and smaller. So you have, don't write this down, just make it make common sense. You've got these large arteries like the pulmonary artery and the aortic artery, but they're sending blood to medium-sized arteries that end up becoming smaller arteries as blood is being dispersed and disseminated. Isn't that right? So you've got large arteries, medium arteries, small arteries. Then from the small arteries, you go to these arterioles, large, medium, and small. Would that make sense? And then from the arterioles, you go to vessels that are actually microscopic. They're microscopic vessels. They're one cell layer thick, and they're called capillary beds. These are capillary vessels that are found in capillary beds. These beds of capillaries are feeding our tissues. Please know, when I ask you, where does all the nutrient exchange and waste exchange and fluid exchange occur, you tell me at the capillary level. Because that's the only thing that would make any common sense. Isn't it? When you go back and think about that artery and that thick muscle wall, can any nutrients be exchanged there? Absolutely not. No nutrients can be exchanged there. Blood is being pumped from there to these capillary beds. Do y'all see the capillary beds right here? You see these capillary beds. Now we're just looking at the system, the systemic thing. See from the left side of the heart, the left systemic pump, and we see these capillary beds that have oxygen-rich blood being brought to them. That's a wonderful thing. And now they're in these capillary beds that have a single layer cell thick. And what can move across quickly? What can move across quickly? Oxygen, gases. What do we call the movement of solids from where they're in high concentrated areas to low? We call that what? Diffusion. We called it just passive diffusion. Did it take any energy? Did it take any ATP from yourself? Not at all. They're just going to move out, oxygen is. And CO2, since it's high in the tissues, it's going to just move in. Did it take any energy? Didn't take any energy for that to happen. That's just beautiful, right? But along with the gases that we obviously know are so important, since oxygen, try to do without it for 4 minutes, see what happens. Since, you know, we obviously know aerobic respiration, oxygen is important, but also getting rid of waste, which is CO2 from aerobic respiration, is a waste product, coming back into the blood. But there's also so much other stuff too. How about the fluids that bathe our cells? Is water going to move out of our capillary beds into our tissue spaces and thereby rinsing and bathing our tissues? We call it extracellular fluid, don't we? Sometimes we refer to it as interstitial fluid, the fluid between our tissues. But our cells are being bathed in fluid. That fluid is coming from where? What vessels? Capillaries. Nutrients are coming from where? Capillaries. Waste product gets sent back to the blood at what level? Capillaries. Okay, so then it's there. By the way, can the blood stop right here? Can it stop at the station for that to happen? Or is it continuing to move? And does it need to be continuing to move at a particular pace? Had it better be moving at a particular pace? We said that it better be because if blood is not flowing at the right pace, what can start to happen? Coagulation can start to happen. That's exactly right. So we need blood moving at a particular pace. And it is moving, and all of that passive diffusion and osmosis is actually occurring, and that's all really good stuff. It's not just one-way movement. It's not just movement outside the capillaries to the tissue spaces. There's also some movement coming back in. But we said this is why it's so important that osmolarity be maintained between blood plasma, and interstitial fluids, and even the intracellular fluids, right? Because it's that influencing how all of those substances are moving, right? Okay. So, but it's being pushed. Now, let me ask you this. Where do you think in this whole little system, and I'll finish this up with capillary beds. So then veins, which are going to be, when we think about the venules, these are tiny microscopic venules are going to lead to veins that are small, medium, and then eventually large veins, the inferior and superior vena cava, right? So we know blood is being returned back to the right, this is called right venous return, to the right pump. We get that. But let me ask you about pressure. So we said that the pump, obviously, where the ventricles contract and are sending blood to those arteries, those close arteries are having to withstand a ton of pressure, aren't they? But the further you get away from the pump, what happens to the pressure? It's decreasing. And that actually is a good thing, because if it weren't decreasing, if the pressure were too high in the blood capillaries, what would they do? Remember, they're only single cell layer thick. What would they do? They would rupture. They would rupture. They would burst. They would burst, they would rupture. And we've seen that happen. We see people who have high blood pressure, sometimes you'll see like capillary beds are rupturing, right? What you'll see that they have nosebleeds because the blood pressure is so high that even in areas, especially in areas where the skin is kind of thin, you'll be able to see. That can sometimes be an indication that somebody is hypertensive. What is hypertensive? High blood pressure. Right. So that's one of the reasons. There are many reasons for nosebleeds, but that's just one of them. So if somebody's hypertensive with no nosebleeds, is that a concern? Yes, it is. So if they're hypertensive. So, okay. And then that makes sense. So let's think about our capillary beds that are feeding our feet and our extremities. And let's think about them. They're way away from the pump, aren't they? But we also have capillary beds that are feeding our visceral organs. Visceral means internal organs, right? So we have capillary beds that are feeding all of our tissues, and we get that the pressure from the pump is kind of low at that point, but can it be so low that the blood stops? No, we don't want it to be so low that the blood stops. Actually, when there's dangerously low blood pressure, what do we call that?
Medical shock.
Well,
Medical
we
shock.
call it shock. Hypotension just means low blood pressure. Some people are naturally, their blood pressure is kind of low. But if it's dangerously low, it's called shock, right? If it's dangerously low, because if it's dangerously low blood pressure, it means that you know by the time blood's getting to those capillary beds, it's significantly low, isn't it? And what we know has to happen is that the blood's got to get all the way back to the right venous return, the right pump. And the right pump and the left pump have to be working in synchrony. So we want it to be just right, don't we? We need it to be just right. So if blood pressure is so low in the capillary beds, so how does blood ever get back to the right part? That's a long way from her toes, especially for standing up, right? Because gravity is playing a little bit of a role there. So how does it ever get back? How does that happen? moving is one of the biggest ways that, but this is why people should move. You know how they talk about now that sitting is the new smoke, you know, nothing as bad as smoking and nicotine. And I'm not just saying that because you think I'm prejudiced about it. I'm not. It's because I've seen people who can't breathe. Okay. So anyway, but it's sitting is not great because what we should be doing is moving, and we need to be moving some. I can actually tell you some people, if I have a chance to look at them, who might be naturally hypotensive. If somebody's naturally hypotensive and they're sitting in my lecture, they usually are moving something. They're moving a foot, they're moving something, and their body's telling them to do that because what's it helping to have happen? Right, venous return. It's helping because their blood pressure is low enough that they have to be kind of moving something almost all the time, even if it's just a cross leg that's moving or something, right? But moving, because when we walk, our skeletal, like this is the calf muscle, as we're walking, the veins that are returning blood back, the veins that are coming from it's coming back. As we walk, our gastrocnemius, right, is our calf muscles, but our muscles are actually pumping the veins. And between each heartbeat, where blood would want to come backwards, the muscle contracting is helping to keep it going in one direction. Your diaphragm just contracting is changing the size of your thoracic versus abdominal cavity. So just the action of you breathing is actually helping right venous return. Moving helps right venous return, right? Correct? Y'all get that? Let me tell you what else helps. Is that in veins, there's something that you don't find in arteries. You don't need them in arteries because in arteries, the pressure's high enough. And these arterioles and arteries, the pressure's high enough. But by the time blood has moved through capillary beds and is being returned in veins, there's something that you don't find in arteries. And these structures you've heard of before, they ensure one-way flow. What are they're valves. So in veins, there are valves. So that between each heartbeat, not only do you have muscles that are maybe helping that, but as blood would want to come back down the vein, the valve closes between each heartbeat. So the next beat, blood will come up and the valve will close. Do you get what I'm saying? So it's keeping blood going in one direction. What do you call it when somebody has, what do you call it? I can only do this because I don't know he won't file assault charges or anything. You will. Okay, so what do you call it when somebody has these veins and their valves might prolapse? And their valves prolapse. So between each heartbeat, blood will pool a little bit and stretch the veins out enough that sometimes you can see them through the skin and they will bulge out. What do you call those veins? Varicose veins. Varicose veins are the veins that you see because the valves in those veins are prolapsing, causing blood to pool back down and stretch out, right? So, let me just slam it down. So, okay, so that's a varicose. So veins have valves, just like there were valves in the heart, right, to ensure one-way flow. And faulty prolapse valves in the veins can lead to a condition called varicose veins. Most people don't get those. That does seem to be an inherited kind of issue, but it can also be occupational. So people, again, who have to stand for long periods of time, does that interfere with the right venous return? And can that interfere with those valves and those veins? And then some people have what are called hemorrhoids. Do y'all know what hemorrhoids are? They're varicose veins in the anus and the rectal anal region. They're just varicose veins. That's what a hemorrhoid is. And people that's also can be an occupational thing. People who do a lot of sitting, especially like truck drivers who are for hours on the road, right? Certainly, you know, and then certainly nutrition and digestion can play a role in how much pressure you're having to put on the rectum. But anyway, yeah, that's all hemorrhoids are varicose veins. Are we good with that? All right. So we do have, what's this term anastomosis mean?
Blood will take another route.
It can take an alternate drainage route, and it certainly does. Would it make sense to you all that not all, I'm going to go through this a second and then come back to it. Would it make sense to you all that not all of your tissues need exactly the same amount of blood flowing through them at all times? So it's not always consistent. If you're in a fight or flight response, what needs the blood pumping to it? The large muscles, the glutes, all these the large muscles. Do you need blood being directed toward your intestinal tract just so that you can digest the last meal you had? No, you don't need it then if you're in a fight or flight response. This is why if you're ever stressed or whatever, you probably shouldn't eat really, because what's happening, I know, I'm such a hypocrite because that's what I do. So anyway, but you really shouldn't, because you're probably not getting the nutrients that you need out of it. You might be getting just the worst, because blood is really not being diverted there. It's being diverted to areas like your larger muscles for fight or flight response. That makes sense. So depending, and what causes that? What's directing that? Your nervous system, but talking to which things? Really muscles, right? In this point, through hormone exchange. And this is how it's being directed. So these sphincters, which we know, if you didn't know, you'll know, a sphincter is a round muscle that controls organ volume. If these sphincters are closed off, is blood going to be going to that capillary bed at the same pace? No, it isn't.
It controls what?
Sphincters control blood volume. Look at these little round sphincters here. And if you'll look at this, these small arterioles that are feeding this capillary bed, you'll see that they're closed off. So that this capillary bed getting the same kind of blood flow. Whereas if these sphincters are open, the capillary beds are filled, right? Y'all have heard of capillary perfusion, right? Have you heard of that? Oxygen perfusion, have you heard? So checking to see if oxygen is getting to certain tissues, getting to them at the pace that they should. Let me ask you something. If you're freezing to death, if you've gone outside and then forgot to put on any clothes, there might be some other issues if that's the case. But if you've gone out and it's freezing and you don't have on clothes, or you're outside for a long period of time, not dressed appropriately, what starts happening to like your extremities? They're getting very cold. They're changing probably color, because does it look like any oxygen's getting to those areas? No, because guess what? Blood is being directed back to your visceral organs to keep your core organs where they need to be. Because guess what? You can live without your fingers, toes, and nose, but you can't live without your core organs being what they're supposed to be. Blood is being redirected, and this is why frostbite can happen. Y'all just saw with the weather patterns that we are having, right? You just saw how many people died. Over 20-some people died in the Midwest, right, with this last freeze thing. People were getting frostbite, which means they were losing fingers and noses in 5 minutes. They were going out and they had on clothes. They thought they had on enough, but it was cold enough that they were losing appendages within 5 minutes. They said frostbite was already happening. Tissues were dying. And it's because blood wasn't getting to the sites. It was having to be redirected, right? Okay. This is an illustration of what a capillary looks like. One capillary bed, and there's many of them in our tissue beds, capillary beds. But you can see that this is one cell layer. You see the nucleus, one cell layer, one cell on this side. They're so small, capillaries are so small that red cells go through them single file. So your blood is carrying, your blood, which is plasma, red cells, white cells, platelets, all the good stuff in plasma. These capillaries are so small that this would be an illustration of. I think that's pretty amazing, isn't it? They're very porous. These are referred to as fenestrations, but that just is a fancy way of saying pores. They're porous so that diffusion of solutes can happen quickly without requiring really any energy. This is just passive diffusion that's occurring. But also at the same time, osmosis is occurring, which should be occurring with water flow. Is almost this, a little bit of a push in one direction to our tissues, replacing the fluid that's been bathing our tissues. Would it be nasty if the tissues that bathe our fluids never changed and recycled, or do you want it completely recycling all the time? Would you want it recycling, or would you want it to be stagnant? Have you ever seen a stagnant pond? Okay, so not a good sight, right? So you constantly want this, and it is, water's moving. Sometimes it's moving a little bit back and forth, but it's definitely moving. This is a scanning electron micrograph, which is an actual visual of the surface of a capillary. So this illustration is pretty on point, right? You can see this. And this is an actual cell. So veins. So we do know that veins are, anyway, I told you how it's returning blood. This is just FYI when you're thinking about, so where is my blood usually? You know, like at rest or whatever, you can kind of think about this. We know that depending on your size, you're going to have about 4 to 6 liters of blood circulating around. And depending on what you're doing, it's going to depend on where it is. I want you to know about blood pressure, and I'm going to talk about blood pressure in just a second. We said we understand that the highest pressure are in the large arteries, and then the medium arteries, the pressure's going down, smaller arteries, and then arterioles, all the way to capillary beds, and then back through venules, veins, and the right side of the heart. So we understand, depending on what where you're measuring, you would see what would be considered normal or not. Where do we often take blood pressure? We can take blood pressure in a lot of different places, but we take blood pressure here in the brachial region, right? Brachial meaning what? Brachion means what? Brachial, arm, right? So this is where we're going to be doing this, and we're going to do this in class. I'm going to want you all to know that the American Heart Association just recently changed guidelines for thinking about evaluating blood pressure. But what you would want to know for an adult is that blood pressure at rest should be 1, and let's just use 80, even though we know it's supposed to be less than 80 is the diastolic, 120 over 80. So what do those numbers mean? The top number is called the systolic value. The bottom number is the diastolic value. So 120 over 80, or less than 80, I guess I should say. And that's at rest. So what does it mean? What does systolic value mean, the 120? What is happening? What are you measuring? Contraction. Contraction of what? Jesus, I don't know like that. Well, no, it's not those. Because what did y'all say? Which chambers are contracting? You just did it for me today. Where does blood exit the heart? From which chambers? The ventricles. Ventricles go to the aorta, is that right? And from the aorta to the system, is that right, guys? So the systolic value, see if this doesn't make sense, y'all go back at it at your leisure when you can really break it down. But the systolic value is measuring that when the left ventricle is at its most powerful. It's when it is at its most powerful. That means that you're measuring the highest amount of exertion being exerted on that interior artery wall. It won't get any higher than that because the left ventricle is at its most powerful contraction. Are you with me? Do you have any questions about that? That's what that top number is measuring. The highest amount of pressure being exerted on that arterial wall, which would mean when the left ventricle is at its most contracted, right? So what does the diastolic mean? Yes, Brenda.
So when it's contracted, does that mean at its fullest?
No, it means when it is.
Okay.
When it has, I have a balloon that is the left ventricle, right? I have a balloon that y'all know is really the left ventricle, and it's closed off at the top, and it's full of blood. It's full of blood. Boom! The highest amount of pressure that just flew in her face is the systolic pressure on the. Do you get what I'm saying? So what is the diastolic? It's when the left ventricle is at its most relaxed. Is there still pressure being on the blood? Yes, it is. It's still pressure, isn't it? And is it measurable pressure? It's measurable. That pressure is measurable in millimeters of mercury. We can measure the pressure. And the diastolic pressure is when that left ventricle is at its most relaxed. So it's the least amount of pressure ever being exerted on a vessel wall. Be a vessel wall, Dakota. You're a little vessel wall. And when you got an opening, you got a lumen. So blood is coming through. Is that right? And I know that vessel is not loose. So blood is coming through, isn't it? Blood is pushing through. The highest amount of pressure stretching it is the systolic. But the least amount of pressure is also important, the diastolic. What's the most important, the top or the bottom number? Why do you say that, Rita?
Because your heart needs to rest.
Well, the left ventricle does need to be at rest, but we're thinking about the blood vessels too. That's the least amount of pressure that's ever being exerted. It doesn't get any, so that's the least amount of pressure. It's a trick question. They're both important. But some would say, truly, some would say that bottom number is really important to know too, because that's the least amount of pressure. Those poor vessels are at least always under that amount of pressure, and it needs to be less than 80 millimeters of mercury. It needs to be less than that at rest. The American Heart Association calls hypertension any blood pressure that's 140/90 at rest, and certainly anything above those. That's hypertensive, 140/90. But the American Heart Association has just changed that. So now we've got this middle between 120 and 140, right? And the 80 and 90. Do y'all see that little range that we didn't discuss yet? You're with me? They're actually calling that prehypertensive, and that's actually a condition now. So you are considered prehypertensive. You're considered to have a medical condition if your resting heart rate is between that area too. That's not a gimme zone. You know what I mean? Any questions about blood pressure and what's considered normal
Can you
for
repeat
adults?
Prehypertension.
What you just said?
Can you repeat prehypertension?
Prehypertension is any rate between systole being at rest between 120 and 140, or diastole being between 80 and 90. Fair? Y'all got that? Okay. It used to be called, they would say, oh, well, just watch, maybe you don't do it, but they're really considering this condition now. So, all right. What can affect the top number? The top number can be very much affected by stress. The top number can definitely be affected by stress and can be the most changeable, if you will. But one of the reasons that some people consider that bottom number to be so valuable in knowing is that that's not usually one that really is affected by that. That is more of a, or something you really need to be paying attention to. Now, I want you to also know about something called the mean arterial pressure. And this is actually really going to be important because they supposedly, when you look at this mean arterial pressure map, this is going to actually mean maybe more to you in the short run about your patient and long run as far as the risk of stroke. So what we like to see typically is this sort of ratio of thirds. So if the systolic is 120, and let's say this is 80 just for easy math, then this mean arterial pressure would be a third, wouldn't it? Because if we took 80 from 120, what would we get? 40. And would 40 be a third of 120? Right? So this is what we'd like to see. If that is off in any way, if this mean arterial pressure is not really that 1/3, then this means that these small arteries are having a lot of pressure being exerted on them at any given time. And this is typically the best indicator of potential stroke. I don't really ask you any of that. I just want you to have heard of mean arterial pressure, because we would like to see that if we subtracted the diastole from the systole, we would get a number that's 1/3 of the systole, right? Okay, so hypertension, and again, this, but and hypotension just means low resting blood rate. Now, some people are just normal to be kind of low. So 90, who's 90 over 60 normal? Yeah, to some people, and I would guess that. So you absolutely, that's just normal for them. But we can't let it get too low, can we? There's no saying that high blood pressure will kill you, but low blood pressure will make you feel like killing yourself. And that's not even something they say anymore now, because that's like a sensitivity thing. But you know what I mean? Because you just don't feel, you might not feel as good, right? I'm not talking about 90 over 60. I'm talking about somebody who's chronically, seriously low. That's a normal for you. I'm sure I was 90 over 60 for 4 decades, right? So as we age, though, is it normal that with aging blood pressure goes up? It's normal with aging that blood pressure goes up because the vessels lose some of the elasticity. And so this is just a normal process of aging, is that blood pressure can go up some. And then obviously what we worry about with true medical hypotension is shock. And the most common cause of shock is going to be hypovolemic shock. And that's on this next slide, I think. I don't know where it is, but it's somewhere. So hypovolemic means hypo low volume, V, volume in the bloodstream, low blood volume. It can be because you're dehydrated. Can somebody be dehydrated? Can put them into medical shock? Are you kidding? And the heart gets a signal to stop. The heart will get a signal to just stop. Yes. Number one cause of death in kids under 5 years old is dehydration. They go into cardiac arrest because they become so hypotensive. Hypotension is not a joke when it's seriously low. So no joke, right? But also hemorrhaging. Somebody can be hemorrhaging and not even know it. So these can be some of the things. Somebody's anemic, so this can actually cause it too. So any of those things. All right. Now what's controlling this are so many different things that are controlling blood pressure and flow. The hormones definitely are controlling it. But as we said, even emotions can control this. So higher brain centers can actually control this. And we've got baroreceptors, chemoreceptors, all of those things are playing a role in controlling blood pressure. I'm going to just go until I find something I know I'm going to end up. These baroreceptors that I was telling you about they're actually placed strategically. This is why, you guys have heard of a sleeper hold that can put people out. The reason is if you turn somebody or stretch somebody's vessels, the baroreceptors are thinking blood pressure's going up, is why it's stretched. It's not because you got some maniac doing something to you, right? So anyway, as the vessel gets stretched, the baroreceptor sends a signal to the heart to slow down and to stop its contraction strength of being as hard as it is. And that can be just enough to lose blood supply to the brain and the person passes out. So this is a deadly kind of thing when that happens. But usually it's keeping everything just right. It's not crazy like that. It's just right. Stress, anger, arousal, any of those things can play a role. So we know it's a lot of different things. Do we know the hormones? Do we know what angiotensin is? It's a what? What is angiotensin? Vasoconstrictor. So what's going to happen to blood pressure? If the vessel contracted, the blood volume didn't change, so pressure went up, didn't it? Blood's going to move faster. Is everybody good? Casey? Angiotensin, vasoconstrictor. If the vessel constricts, blood pressure's going up because the volume didn't change. Aldosterone, sodium being pulled in from the kidneys. Aldosterone from the adrenal glands, right? Y'all remember these hormones. You will be quizzed on all of this Wednesday. All of these hormones again. Angiotensin, a vasoconstrictor, blood pressure goes up. Aldosterone from the adrenal glands targets the kidneys to pull in sodium. Where sodium goes, what follows? Water. Blood volume goes up, but blood pressure goes up, right? ADH is going to cause you to lose water. So you're losing, ADH is going to cause you to keep water in and stop making so much, I apologize for that, stop making so much urine. So pulling the water in does the same thing. It's synergistic with aldosterone. Epinephrine, norepinephrine, causing blood pressure to go up because they're causing the vessels to constrict, aren't they? So this is going to do that. And then those are some of the things that affect ANF does the opposite. All right, so anyway, just looking at rest, where blood would be, versus if you're active, where blood is going to be. That's just FYI. Capillary exchange is where we said all the exchange is happening. Diffusion, and it can happen through transcytosis and a lot of different reasons, but that's just FYI at that point. Okay. These are just pictures. Those of you who like to see these pictures and the different pressure that's being exerted on these, then you can see this. I've already talked about most of this. Do we know what edema is? It's an excess of fluid in the tissue spaces. If there's an excess of fluid in the tissue spaces, can the tissues work the way they're supposed to work? Can they? Or are you going to start to see problems with the different tissues? Kidney failure, water retention, and hypertension when the kidneys are not filtering. Histamine. We said histamines makes the capillaries more permeable, didn't we? And we said that fluid will leak. Fluid will leak into the tissue spaces. Histamine doesn't just do that to the capillaries, it also causes vasodilation. Thank you, Arthur. About this, I've got the thing in my office, the little slip. No, it just said came in piecemeal. I called them about that order, and they said they didn't know why they sent it in 2 pieces. So they sent it in 2. They sent the half of it, and then they sent the other one for us. There was one order. Yeah. All right. So edema. You can have it because of poor venous return. We said that, we talked about that a little bit. Congestive heart failure, pulmonary edema, kidney failure, and histamines, we said relaxes the blood vessels. That lowers blood pressure, but also causes them to be leaky. Histamines also initiate pain receptors, so we had talked about histamine. Hypoproteinemia, again, if the osmolarity changes, is that going to influence how water moves between 2 spaces? It absolutely is, and proteins play a huge role in osmolarity. So cirrhosis, what is cirrhosis? What is cirrhosis? Cirrhosis is actually hardening or scarring of the liver. Cirrhosis can be caused from a lot of different things. It can be caused from alcohol and or other drug abuse. It can be things because the liver is a filter of blood. So there are many drugs that actually get filtered through the liver. Alcohol isn't the only drug that gets filtered through the liver. So people who take like acetaminophen and ibuprofen or whatever, are they straining their livers? They definitely are. So so cirrhosis can be caused from alcohol. It can be caused from other drug abuse. It can be caused from other things as well, even autoimmune diseases. So cirrhosis it's a lot of people hear cirrhosis and they think somebody's an alcoholic. That isn't always the case. It can be caused from other things as well. But if the liver's not functioning, if the liver's not filtering, then blood can back up and you can get something called ascites. What is ascites? Anybody know what that is? Did we do that in here? ASCITE. It's fluid in the abdomen, building up in the abdomen. So it is. And then famine, we said, is because of the low protein causing hypoproteinemia, burns, kidney disease. And then you can have obstructed lymphatic drainage. Now, we haven't really talked about the lymphatic system, but I've talked to you all a lot about this. Now, listen to this. I told you that in the capillary beds, it's not just nutrients moving out and waste moving in. There's also water moving out, water that's bathing our tissues. But where's the water that's in our tissues going when more water moves in? Anybody know? So you all are little cells that are making up tissue. Water comes from the capillaries, bathing you guys, right? But there was already water here. Where does it go? As water's pushing out and bathing you all, the water that's there moves into vessels called lymphatic vessels. and that water that's moving into lymphatic vessels is going to eventually get returned back to the bloodstream. This keeps water moving and bathing your cells. Do you hear me? But most people have never really thought about lymphatic vessels. Everybody in this room knew you had arteries, and everybody in this room knew you had veins, right? You might not have really thought about them as being a closed system. They were. But most people don't realize that on autopsy, when you look at somebody, there's a whole other set of vessels. They're called lymphatic vessels. Lymphatic vessels are returning the fluid that's been bathing your tissues back to the bloodstream. If those lymphatic vessels get blocked, can the fluid that was bathing your cells get returned? Or is it going to build up? It's going to build up, isn't it? So if there's a blocked lymphatic return, this is going to be bad. You guys have heard of elephantiasis, have you? Have y'all heard and seen elephantiasis? No? How many have not heard of? Raise your hands if you haven't heard of elephantiasis. All right, well, I want you to Google it. You'll hear it, if those of them are in micro, you'll hear about it in micro. Elephantiasis is actually the real disease. Elephantiasis is caused from worms. These are worms that end up being, you can get, it's mostly in northern Africa where you can get exposed to these parasites that end up moving. They love to live in your lymphatic vessels. So they will actually move to areas like the popliteal, lymphatic areas, or the cubital regions, and these worms will fill up the lymphatic vessels like spaghetti in these vessels. So fluid that's bathing these tissues can't get returned. They will get huge. They will get like 10 plus times the size from where the blockage was. It's no joke, right? And that's why it's referred to as elephantiasis, because you'll see people's feet from the knee down look like an elephant's foot. It looks just like it. You'll see pictures where scrotal sacs are touching the ground. That was like go too long when that happens. So anyway, you'll see, and it's we don't want lymphatic return blocked. This is why when people have cancer and they have lymph nodes removed and lymph vessels impaired, can there be excess swelling from that site, right? And it's because the lymphatic vessels have been compromised, right? So you can get edema for any of these regions, any of these reasons. So, okay, so consequences are that you've got fluid being lost to tissue spaces. Is that taking blood volume down? Yeah, so that can put you into shock, because we said dangerous thing. But also because there's so much fluid, can you get nutrients to your tissues? You can't. So necrosis means what? Tissue death. It's going to be death to the tissues, right? So tissue death. Pulmonary edema. You've got fluid in your lungs. Can you move your lungs? Can your lungs expand and contract the way they need to? The only reason y'all have air moving right now is because your lungs can change shape. If your lungs lose the ability to change shape, if somebody comes and sits on your chest for too long, would you suffocate? Would you suffocate? You would, because your lungs can't change shape. So that will cause suffocation. And then cerebral edema doesn't take long for this to kill you, because you got fluid building up in the brain. And this is, obviously bad. Headaches, nausea, seizures, and coma, and they're progressing really rapidly when this is starting. All right, this is why can they have fluid overload? Can you overload somebody with fluid? Can people do this to themselves by drinking too much? Yeah, do y'all remember not long ago, it was that young mother who had won a radio, she won the radio contest for something for her child, but she died before she got to the hospital because of cerebral edema from drinking too much water. So yeah, you want to be careful of fluid overload because of cerebral edema. Okay, and mechanisms, we said, just moving. Is moving helping venous return? Muscles kind of milking, if you will, skeletal muscles. But also we said just breathing, so thoracic muscles changing too. shock. I'm sort of going through this, but like I said, I think a lot of this we've talked about. The most common shock is hypovolemic shock. So you are either dehydrated, burns. What was the #1 concern with burns? It's not infection. You might not get to live to have an infection. What's the #1 concern with serious burns? Hypovolemic shock. That's the #1 concern. As soon as you can get them balanced with their blood volume, as soon as you get them balanced, then you can worry about infection. True, you would. But anyway, trauma, those are going to be reasons. So you're hemorrhaging. And then obstructed. So what is an aneurysm? What is it? And you would want to know, what is an aneurysm? This is a blood vessel, right? And blood is flowing. Is that blood flowing? And with each heart rhythm, blood, well, it's never backing up where I was just doing like this, but with each heart, we understand with each heartbeat, it's moving, isn't it? And we said that when we think about vessels, we know that vessels have several layers. We have an inner layer, an outer layer, and the middle, what? A middle muscle layer. Is that right? For these vessels, except for capillaries, the other vessels are like this. They have those 3 layers. Now, when blood is pushing through, because the pump's pushing blood, if one of these layers becomes separated, if it becomes separated, then you can get what's called, and I've heard it called a blister. It's like a little blister on the vessel wall. So every time the heart pumps, is blood going into that blister. You get what I mean? And then coming out. Now, most aneurysms, and supposedly most of us are born with an aneurysm or 2 somewhere, and it's never going to do anything more, even with all the pumps of your heart that happen over a lifetime. Okay? But not some aneurysms. Some aneurysms are going to rupture. They will grow. They get bigger because of the constant pressure being put on them, and they'll grow. And once they're over a certain size, if you're lucky enough to know you have one, but once they're over a certain size, then you got to risk surgery and go in there and repair it. But if you don't know you have it, what can happen? It can rupture. And if it ruptures, do you have the risk of bleeding out? You have the risk of bleeding out. The closer it is to the pump, like if it's an aortic aneurysm, descending aortic aneurysm, or femoral, these are large arteries. It usually, especially if it's aortic, you have 2 minutes. If it's a cerebral aneurysm, the worry is because of the central nervous system and the brain, and so you might not even have that. If you survive a ruptured aneurysm, that's a lucky person, isn't it? That's a lucky person. So if it's cerebral aneurysms, they usually talk about a headache, like that people survive them, would say that, no, like that's a real headache, so it was just horrific. So incapacitated type of event that happened, and usually it's a sudden event that happens. It's usually, my EMT people never responded to aneurysms. People with aneurysms. It's usually a life-threatening event. Okay. Any questions for me? We've covered, I think, a lot of what I wanted to cover with this. I do have just a couple of, so hypovolemics most common. Can we stand for so long that our blood pressure drops and we pass out? This is why they say not to do what? Lock your knees, right? You should always be doing something, sort of moving a little bit, right? And I know y'all probably all seen people who've done that. Septic shock is when you have an infection that is causing this to be, the toxins are actually triggering this, a drop in blood pressure. So this can happen. And then you can have an allergic reaction with widespread histamine release that causes a sudden drop of blood pressure. These are people who have those allergies that they have to keep EpiPens with them. So peanut allergies, shellfish, bee stings, right? Certain allergies that you have to keep an EpiPen, because this can happen really, really quickly. Most of the time we can compensate. So if we're dehydrated or we see a patient's dehydrated, we're giving them fluids, aren't we? We see somebody who's in anaphylactic shock, we're giving them EpiPen, and we're working on that. So we're going to try to help them. Somebody who's locked their knees, fall out, they get horizontal, and then do they wake back up? Yeah, they do. So that's like compensated. Decompensated means without medical intervention, you're not going to make it. So you're going to have medical intervention to actually make this. And there's just two other things, TIA and CVA. Make sure you know what they stand for. TIA stands for transient ischemic attack. It used to be called a warning stroke. They used to, and I know this literature says this now, warning stroke, but now they're actually referred to as strokes. A CVA is a cerebral vascular accident, which is what people think of as strokes. But a TIA is also a stroke. The difference between them is that with TIAs, the symptoms typically are going to resolve and go away within 24 to 48 hours, right? So they may lose like, even half of their body function might be lost, or not be able to talk, or not be whatever. But typically, it's going to resolve within a pretty short period of time, within 24 to 48 hours. Sometimes it takes a little bit longer. That's a TIA. A CVA is a stroke that if they survive, there's going to be permanent damage and compromise. Cerebral vascular accident. All right. Do y'all have questions for me? I actually will do one more thing when we come back. But we kind of are finished the cardiovascular section except for anatomy, and I'm going to talk about anatomy when we start on Wednesday. But y'all do see that as far as vessels go, the veins and the arteries, they have very similar anatomy, where this middle wall is muscle. Veins have a much smaller muscle wall, though, because veins don't have as much pressure being exerted on them. So arteries have a much thicker middle muscle layer. That sounds good. I mean, that's a big difference, but okay. How do you feel about the cardiovascular system? How do you feel about blood, the pumps, the vessels, and understanding how these are being delivered to all their tissues, right? All right, so you guys review. Make sure you review the hormones. There will be a lecture quiz that is really comprehensive on Wednesday. Y'all have about a 10-15 minute break, and then we're going to look at hearts. I need to give you today, and I'm going to go do it right now. I need to give you all a list of the structures that you would need to label for a heart lab, and I will bring that to lab in just about 15 minutes, and we'll do it in here. We'll bring the hearts in here, okay? So we don't have to wait for them to leave. We'll bring the hearts in here. So take a break.
It's 19.
It's the hematology, heart, and vessels. I don't know the numbers.
Oh, for the quiz?
Yes.
Oh, okay. It's fine. It's taking it.
I'll be right back. I've got to get y'all's list of the structured
The lecture.
Oh,
Did I get my lecture link back from last week?